Okay, everyone, we're going to officially get started. Thank you so much for being with us today. I hope you all had a wonderful, long 4th of July weekend, had time with your family and friends, and were able to rejuvenate if you needed it. As you can see, today we're at the half-year mark with what's going on at COA, and we have Nicolas Ferreyros, our Managing Director for COA, who's going to be providing us with a mid-year update, what COA has been working on. And when we say COA, that involves all of you. Thank you so much for being with us on all of our advocacy work. And following Nick's information share and presentation, I'm going to be talking to you about the opportunity to bring your elected officials, whether federal or local, to your cancer centers. So Nicholas, Mr. Ferreyros, thank you for being with us today.
Thanks, Rose. Hey, everybody. Glad to be here. Always really great to be on these advocacy chats. As Rose mentioned, I'm Nick Ferreyros, Managing Director at COA, and I wanted to sort of walk you through a little bit of the mid-year update, really talking about some of the major policy updates that we've seen so far in 2025 and where we are and what lies ahead. The first bullet here on the screen is the state of DC today. Usually when I talk about these things, I say it's a mess. DC's been a mess for a very long time. I still think it is incredibly partisan. We have sort of had all the air sucked out of the room with reconciliation, the One Big Beautiful Bill Act that I will talk about in a minute. But, just as far as fundamentally how DC is operating, how everyone in DC is feeling, really depends on what party you're in right now. So it's been a whirlwind year and a lot of different things, but we have a new political reality in 2025. As we're all well aware, the Republicans came into power with this really sort of deep-seated sense of a mandate and have wasted no time launching a fairly, ambitious legislative and regulatory effort that so far has been very successful. Regardless of how you feel about them, it's been very successful. It's been a very sweeping policy change in the environment. Polarizing, of course. We've got immigration debates, vaccine debates, tariff discussions, and of course, major changes to healthcare programs. Just last week, literally right before the 4th of July holiday, Congress was finally able to pass what President Trump also signed, what's been officially dubbed the One Big Beautiful Bill Act, otherwise known as the Reconciliation Bill. For those that are not really familiar with how DC works and this sort of wonky terminology, reconciliation is a sort of a special legislative tool that lets Congress pass budget-related bills. So bills, they have to be tied directly to budget. All the elements have to be tied directly to budget with just a simple majority in the Senate. What this avoids is that sort of partisan gridlock that comes from the filibuster threshold, which is a 60-vote filibuster threshold that sort of tends to stall a lot of things out in the Senate. And that means if one party controls the House, the Senate, and the White House, they can advance major fiscal changes without needing support from the other party, without needing to build consensus. And so going back to what I said earlier, sort of this really partisan, divided environment. And it depends on if you're a Republican or a Democrat, how you're feeling right now, because, Democrats are pretty listless, beaten down, not succeeding at their priorities or at stopping the Republican machine. And the Republicans have been very successful in getting the things done in the last 6 months. The One Big Beautiful Bill Act passed with a razor thin margin, really long party lines. You had 2 House Republicans and 3 Senate Republicans that crossed the aisle or voted against it. You had the budget hawks that talked a lot about their concerns with the costs of the bill and the rising debts that it would add. And the debt ceiling. You had moderate members that were very concerned about what the bill included, such as Medicare and the healthcare impact. So it really was, it still remains a very divided environment in DC. But that said, the One Big Beautiful Bill Act, this is primarily being discussed as, a massive tax cut package. But all of the headlines, all of the discussion has included sort of Medicaid and healthcare policy. And that really is one of the largest elements in this bill. Some of the most sweeping Medicare, Medicaid, health policy changes in the last 15 years. Really big since the Affordable Care Act, really. The big thing that all the headlines are driving is Medicaid changes. You've got Medicaid work requirements for the first time in the program's federal history. You got introduction of some out-of-pocket costs and copays for Medicaid. All of these add up to, all of the healthcare changes add up to about $1 trillion in health program cuts over the next decade. There's no dancing around it. A lot of the projections show, 12 to 17 million Americans losing healthcare coverage because of it. You've got changes in Affordable Care Act subsidies, that's the health insurance exchange subsidies, changes on state provider taxes, which a lot of states use to fund their Medicaid programs and to sort of juice the Medicaid system. It's a very complicated formula there. Changes to the medical education program fundings and student loan programs. So it's a really sort of a big, broad bill, lots going in there. Of course, you're making permanent some of the tax cuts from the first President Trump administration. But on our end, obviously I'm going to focus on the health policy stuff. These aren't theoretical or abstract. They're not only applicable to to sort of big picture. They really do directly impact a patient's ability to access care and coverage, especially those that we deal with, patients with serious illnesses like cancer. So the One Big Beautiful Bill Act is a massive landscape shift in health policy. I think a lot of the reigning consensus right now, big picture, is that the losers of this bill are hospitals, and a lot of what's going to change is hospital funding out of this. Unfortunately, not in the areas that we as an organization have really focused on a lot over in recent history, which is addressing things like 340B and consolidation. And site neutral payments. I'm going to go to this slide for a second just to talk a little about our overall priorities, because I feel like it's important level setting in what didn't make it into the bill. Going into the end of last year, you may recall at the end of last year, we had come very close on a large budget package, and we're going to have to go through that again at the end of this year, a large federal budget package that would have addressed so many of these issues. This issues list is actually a similar year to year because Congress has not been able to pass bills through regular order. You often have to do it through either reconciliation or these big budget packages, omnibus packages at the end of the years. So I put this up here to say, we have a big, long agenda of issues that we've been working with at COA and community oncology, and I think a lot of patient advocacy organizations have been working on that. Number one, ensuring sustainable provider payments. We have had Medicare reimbursement for physicians of all types that have not kept up with inflation. In oncology in particular, have not been kept up with inflation. In fact, keep getting cut. You have a growing challenge of prior authorization, utilization management. That's just sort of barriers to patients getting their care. You have this growing world in the middle of pharmacy benefit managers, or PBMs, that are abusing patients and hurting them at the pharmacy counter and restricting access to what kind of drugs they can get, where they can get them, and when they can get them. You have hospital challenges. Hospitals are 1/3 of healthcare spending in this country. They are not a cheap site of service for patients. Most healthcare can be handled outside of the hospital setting, but you have growing hospital monopolies. I think 1/4 of all regions of the United States have no healthcare competition for hospitals. A lot of other issues as well, cancer drug shortages, access to drugs. I say all of this to say, we had a laundry list of things in healthcare that we wanted to fix that were not addressed in the One Big Beautiful Bill Act. And there were a lot of things that made it onto the table for this. Some of you have listened to these advocacy chats in the past, have heard about the Stark Law. This is a reinterpretation by CMS a couple of years ago that restricts the ability for patients to have their medications delivered or picked up by their family member or caregiver. The government, in its infinite wisdom, has decided that if you are at a community oncology practice and that is happening, that is considered a Stark Law violation, and they have effectively made it illegal. Patients can now no longer have their medications delivered or couriered to them, or they cannot have their caregiver or family member pick them up. So if you're at home sick with cancer and you need to get your oral cancer medication, your loved one cannot go pick it up at the pharmacy counter for you. You have to get up out of bed and go deal with that, which is obviously not ideal, and it's a huge interruption. So a lot of these things were on the table with the One Big Beautiful Bill Act. Unfortunately, most of them did not make it in there. And that's because in reconciliation, as I said, everything has to be budget related. It has to pass what's called the Bird Bath, BYRD, and you can read more about that. And that was, that's an old Senate issue where the Senate parliamentarian, who's sort of the referee in the Senate, gets to decide what can and cannot be included because of how closely it ties to budget-related issues. So far, of all that list, only thing that really made it was a very small, not even a meaningful, but small step towards addressing the physician fee issues, a 2.5% increase, which barely covers the roughly 30% decrease that we've seen over the last 10 years, effectively, after you account for inflation and ongoing cuts. We still have a lot from this list to address going forward. It's still a lot to go forward. Going into it, we were very busy in Washington. The COA team works nonstop. Our government relations federal advocacy team works nonstop. About 3 weeks ago, as you see from these photos, we had more than 100 people in Washington, including many advocates from CPAN and who may be on this call, in Washington working the hills of Congress. It was a hot day. We were running around everywhere. But it was a really impactful day. Even though we may not have actually succeeded on a lot of the priorities, what you do is you keep them top of mind for members of Congress, and you keep them and their staff knowing about what's happening on the ground. We've been working hard. We continue to work hard. Also at the state level, we've been working in 45 plus states this year, 300 plus bills, addressing lots of these issues, addressing prior auth, 340B, PBMs, you name it. The advocacy is working, but it is a long game. And just because, this one bite at the apple, we didn't make it, we didn't do it, we didn't get where we needed to go, doesn't mean we have to give up. And so what's ahead? We've already hearing talks about a second reconciliation bill this year. Congress is looking to continue addressing a lot of those issues that they didn't get done. This could include PBM reform, a more permanent, meaningful physician pay fix, Stark drug delivery issues that I talked about, and we're going to fight for every inch of that. Also, as I mentioned, government funding is expiring again on September 30th. That is going to be a big flashpoint. That's going to be a big area for legislative action. We have another Hill Day, a smaller one, more focused and targeted in the fall around that as well, and looking for opportunities to attach our key priorities there. And of course, any day now, the biggest federal healthcare rules of the year, as far as we're concerned, the physician fee schedule and the hospital outpatient payment schedule, PFS and HOPS, should be dropping. And that sort of sets payment for the year ahead, but also is a really good indicator of how the government and administration is thinking about things. And we're not slowing down. And, a lot of these fixes, a lot of the challenges, if you ever want to get a primer, we only have so many minutes on these advocacy chats, is in our prescription for healthcare reform. I keep this on my desk and look at it almost every day. If you want to read it, it's on our website. It's highlighted right there on the homepage. It's a real blueprint for how to move ahead on a lot of these issues and what you can do. Going back to sort of what I said earlier, advocacy is a long game. It requires ongoing investment, ongoing commitment. It is not something a one and done. We don't just get to show up, airdrop into Washington D.C. one day and say, "Okay, we solved it. Now you go and do it." You better believe that we need to be there all the time, regularly. The squeaky wheel gets the grease. And on this list, you've got a lot of different ideas or ways you can get involved. Contact your elected officials. Keep letting them know what you think on all of these issues and all the issues. But number 4, and what Rose is going to talk about, is meeting with your elected officials. This is one of, if not the, I think, most powerful weapon you have, because so often in Washington, these concepts are abstract. They're big picture. They don't really know how they apply in the real world. You have a 22-year-old, fresh out of college, there sitting there across the table, who has their boss's ear, but doesn't quite understand, how it operates in a practice, and what happens in Washington D.C., how that impacts Des Moines, Iowa, or San Diego, California. That's the real world. That's on the ground. That's where policy rubber meets the road, and your voice and having them in your practice with a sit in my chair visit, for example, is so powerful. And with that, I'll turn it over to Rose. And of course, I'll be here. If you have questions, we can throw them into the chat for later on. But with that, Rose, I'll let you talk a little bit about sit in my chair.
Thank you. Thanks, everyone. So as Nick mentioned, and I've mentioned several times in previous advocacy chats, any presentations that any of you have been part of, is what's really exciting about COA is that we're working a very wide range. So it's very exciting to go to Capitol Hill. I know for many of you that were there with us recently and those that have joined us in the past, it's super exciting. But we're also doing so much work locally and at the state level. And we've been doing that for years. And it is so important, especially in the last few years where state advocacy is making such a big difference with what's happening nationally. So for years, we've done this event called Sit in My Chair. And the verbiage Sit in My Chair came because we wanted to give our policymakers an idea of how valuable community oncology practices are. And the best way to experience something is to actually put yourself in their shoes, or in this case, sit in my chair. So the event is an opportunity also for the local practices to either form a new connection or re-engage a prior connection by reaching out. And there's so many exciting things about Sit in My Chair event is oftentimes, politicians, when they get invited to everything, but they absolutely love coming to the cancer center because of the practice, the people, the nurses, the doctors. These are well-respected people in the community. So it's almost a 100% yes that when you reach out, whether it's to a local official or to one of your national representatives, that you're going to get a high response rate. So what is it? It's meeting with policymakers in the community oncology practices. So again, we showed you the photos of us meeting on Capitol Hill, but we also meet locally in the practice. So it's very easy. We give you all the tools to do it. We've been doing it for many, many years. And as I go through a couple of slides, you'll see how easy this really is. Next slide, Nick. Okay, so what do you do before the event? And it really is something that many of you have heard me say before is let's not overthink things. And I know because I often overthink everything, but we make it really simple. So before you even think of having an event, because you might think, oh, that sounds very intimidating. It really isn't. And we're here for you. You can definitely reach out to me or anybody on the COA team and we can help answer your questions. Before the event, if you're going to want to be sure of who your state and federal representatives are, we have a resource for you, openstates.org. And here's an image of what the website looks like. And again, everything is on our website as well. You'll start to plan the visit, and the upcoming slides will give you some step-by-step. And we've actually made it even simpler. When we first started doing a toolkit, it was pretty expansive. And we listened to your feedback and we understood that that toolkit, even though we were trying to be very thorough, came across as a little bit intimidating. So it's just a few steps that are very easy to follow. If you just go back one slide, Nick, please. So the federal, the August recess is when our federal members are in their home districts. But again, just to really reinforce, it's up to you and your practice based on your needs, who you want to invite in. The state legislative calendars vary. Next slide, please. Okay, so what are the resources? I know that this might not be the easiest thing to read right now, but when you do go to our website and you can download the toolkit, this is what you're going to see. It's this simple. It's 3 pages. with very clear information. And remember, brevity is important. It's not short because we don't have a lot to say. It's condensed because we're only giving you what you really need to make this happen. So you will be able to download this. And then also just a reminder, our advocacy chat slides are available on YouTube and Facebook as well. So YouTube is a little more where we have everything. Sometimes we don't have it on Facebook. Next slide, please. So what happens? Okay, so you reach out, you might have some back and forth with your emails. Most likely you'll do that, or phone calls. It depends on what your relationship is. But you will hear back from someone at the representative's office. So now you're excited. They said yes. What do you do? Number one, pat yourself on the back. Don't panic. You can still do this. And we're still here for you to answer all your questions. So what you do is you're going to bring the member into your practice, and you're going to give the member a walk through your practice and give them an idea of what it's like to be a patient. In all of our years of doing this in my chair event, I've gotten several questions in the comments, but one was really interesting to me. And a person said, well, Rose, I don't really think that just having a member of Congress or a local representative come to the office is ever going to make them know what I've been through as a cancer patient. And I said, you're absolutely right. I'm a long-term cancer survivor. There's no way anybody's going to know what we've been through. We understand that. We are just giving them the opportunity to stand in line, wait at the receptionist desk, wait to be called back to the lab, maybe even have to get on the scale, do all these things. And it's really, really impactful for our members of Congress. In these two photos, these are very recent events. This was actually our events from last year. And on the bottom left, you'll see this is Eastern Connecticut Hematology Oncology. And that the gentleman on the right is Congressman Joe Courtney. I've had the pleasure of meeting with him locally and at the national level. And he's there meeting with Dr. Kapoor, Dr. Patel, and going through the entire practice. On the far right is another event that was led by one of our chapter leaders in New York, Chelsea Clark from Hematology Oncology Associates in Central New York. And you can see this actually happened very spontaneously as well. The congressman from New York came in, and there you see there's patients that were waiting, in the waiting room like we do as patients. So it's a very, very real experience. Next slide, please. Okay, so we also have set up to sit in my chair that the representative goes through a mock cancer treatment. The far left, you can see this is Florida Congressman Gus Villarakas going through, it looks like about to do a sample blood draw, and Congressman Andrew Garbino from New York last year going through something similar. So they actually sit there and kind of get an idea of what it's like to be a cancer patient. And also they're being treated so well by all the patients and nurses. And this is not just because they're members of Congress or important people locally. This is really how the community oncologists treat all of their patients. So as they're going through this process, they're really gaining a deep understanding of why it's so important to keep these community cancer practices open. Next slide, please. Again, it's a great opportunity to show every part of your practice or whatever you're comfortable showing. Something we don't talk too much about, but it's a very real part of community oncology is also a major employer in communities. So when the members of Congress, or again, your local representative, get to walk through the practice, they're understanding all the different departments. Oh, this practice has a pharmacy. This practice has in-house radiology. There's financial counselors. So it's a great way, not only to show, what you do for patients, but how important community oncology is as an employer in that local community. And again, FCS, a Florida Cancer Specialist, and Eastern Connecticut Hematology and Oncology with 2 representatives. Next slide, please. Okay, so what happens when you have them there? What are you going to talk about? So, you give them a tour of the practice. And let me pause for a second. In terms of the timeline, that will usually depend on how much time the member has. But I really believe you need at least 45 minutes to an hour. That would be ideal. Sometimes it's a little bit shorter, sometimes a little bit longer. But as we say in advocacy, you always want to have an ask. What you see on this slide is what we asked for when we were recently in Washington in June. So we're supporting our national efforts. It's all blended together. So this is a sample of some of the asks. Number one, as you can see, the header is overall, the message is always, let's make sure that independent community oncology practices can stay open. And we know there's so many obstacles to the practices remaining open. So remove patient access to care obstacles. Again, as a reminder, words like prior authorization, cancer drug delivery, those sound so policy-oriented, but at the end of the day, and they are, but at the end of the day, it's people interfering with the patient-physician relationship. We want to make sure that patients have access. We talked a lot about Medicare reimbursement. And I know oftentimes, because people have said this to me directly, when you think about a doctor getting reimbursed, you think, oh, another rich doctor. No, this is literally about cancer centers having the ability to keep their cancer centers open. You have to buy chemo chairs, you have to buy skills, you have to refrigerate your medication. So that is very important. It's ultimately a patient issue. Increasing patient affordability. Nick talked a lot about site neutrality. Why should it cost so much more? Why should community oncology not be reimbursed fairly when hospitals are charging so much more? It makes absolutely no sense. And reform the 340B program. And we've done a lot of advocacy chats and white papers and talks about 340B. And as always, we have a lot of additional information on our website. Now, of course, at your own practice, you can also ask or address any issues that you're dealing with at the state level. And you have a very, very eager audience. Next slide, please. Okay, so what happens after the chair event, and hopefully what happens anytime we go anywhere, is we automatically write thank you notes. So again, we give you some samples and some key points that you probably should address. Mention some of the advocacy points that we talked about. If you have a personal story and you feel the need or you desire to share it, definitely go ahead and include that. We want to do a call for action, ask them to support some of the initiatives that we're working on, and then always offer to be a resource. And remember, no one has to be an expert in everything. Some people are policy experts, some patients have the survivor experience, some people have some other specialty, but believe in yourself, you definitely have something to offer as a resource. And if you don't feel you're the person, reach out to someone on the COA senior leadership team, and we can definitely assist you. Next slide, please. Okay. Excuse me, I have to get a little sip of water. Remember, ways to stay engaged. I love what Nick said in his presentation. We don't just airdrop into DC for Hill Day. Those are the really cool, fun, exciting events. Nobody's going to deny that. Our conference, amazing. But there's so many other opportunities. So again, thank you for those of you that are on this chat. Stay engaged, stay informed, stay up to date. Sign up for our CPAN newsletter. If you did, then you saw the great photo of us on at the conference. Visit our website. We're very, very timely. There's always something new on the COA website. Share your story. We still have that on our website. You can share your story. Follow us on social media. Next slide, please. And August, summer break. I have to hope you all enjoy that fun summer vacation image. And thank you to my assistant, Tracy Banks, who's always does such a great job working with me on all these fun things. But we will be back in September. And here you see my colleague, Sheila Plantia, the Director of Practice Support. And she has many other responsibilities within COA. September is National Hunger Month, and that is a perfect tie-in to an initiative that COA has been involved with for a few years now, and that's health equity. So Sheila will be our guest, and she'll be giving you some insight into the work that we're doing, including having a new committee name. But this is if I could draw your attention to the very bottom of the slide, CPAN Advocacy Chats, educational conversations on cancer advocacy and policy. So once again, I hope you enjoyed this and are leaving today a little more educated and informed, and we all will get smarter and learn together. Thank you for being with us. And Nick, thank you so much for sharing your insight with us today as well. And I hope everyone enjoys the rest of their day, and we'll see you in September.